very good morning to all of you, and it's an honor to be speaking in this particular session, a joint collaboration between the Bombay Spine Society and the Association of Spine Surgeons of Nepal on avoiding complications in thoracolumbar Koch spine. The previous speakers have covered most of the topic, and preventing complication is just about sticking to what they have mentioned. So to begin with the case, we have two cases, almost similar ones, of a D12L1 Koch spine with similar amount of kyphosis. Now you can see in this, one case went on to complete healing and remodeling of the lesion, whereas the other case landed up in progressive kyphosis and late onset neurological deficit. Both these patients have received the same type of treatment, including the antituberculous medicines, and it was surprising to find a variable result. Now, there are certain variables when it comes to treatment in tuberculosis, like the disease variables, the extent and location of the disease, the presence or absence of drug resistance, the patient factors like the age, the immunity, and the surgeon factors like decision making and the surgical technique and expertise of that particular surgeon. However, certain basic rules apply. The road, if we follow it properly, is clear cut and straight. We need to have a high degree of suspicion. Biopsy remains the cornerstone of diagnosis. Tuberculosis is basically drug management. The indications of surgery are very specific, and we need to give special attention to the biomechanics and the surgical execution. It is only when we try to take a shortcut do we land up in complications, and we frequently name them failed surgery. However, we need to have a relook and reassess whether it is really failed surgery or is it the surgeon which has failed. So coming to the basics, if we have a look at all these pictures and wonder which of them is tuberculosis, the answer is none of them. So the point is that multiple lesions can mimic tuberculosis, and we really need to make an attempt to diagnose these conditions. As I said, the cornerstone of diagnosis remains the biopsy. Ideally speaking, each and every lesion should be biopsied in today's day and age. There are multiple ways in which you can do it. It could be CT guided, sonography guided. CM is something that we all can do as orthopedic and neurosurgeons. And open biopsy is something which we all take on table. The accuracy is more than 80%, and the things to ask for are a histopathological examination to rule it out from different conditions, gene expert to rule out rifampicin or INH resistance, and then obviously to ask for sensitive drugs. Drugs always remain the first line of management. Always involve a chest physician or even a simple physician, because in case these lesions turned out to be resistant lesions, then probably you are caught off guard. Always suspect drug resistance like MDR, XDR or TDR, especially if there is no clinico-radiological improvement, and consider starting second line drugs to prevent surgical failures. We need to understand that tuberculosis is basically a medical disease, and antituberculous treatment is mainstay of treatment. Do not treat the radiological picture. We all know that radiology heals with good, sensitive, acting antituberculous treatment. Indications for surgery are very specific: neurology, instability, and deterioration of pain, which is a relative indication. There are certain special conditions like pediatric tuberculosis, which was already mentioned by the previous speaker, where the aim is to prevent kyphosis, and there are well described signs for this, like spine at risk signs. Finally, we need to make sure that we pay special attention to the biomechanics. If we understand the load bearing column of the spine, it is composed of two main columns, the anterior and the posterior. In tuberculosis, it is usually the anterior column which is destroyed, so very important to pay special attention to the anterior column and reconstruct the anterior column, or else, especially in junctional and thoracolumbar tuberculosis, it is going to land up in kyphosis. So here is a case of a 45 years old female, 120 kgs, who had resistant Kochs. The patient did improve after posterior surgery. However, here you can see on the CT scan, the patient has got an anterior void. That is where we decided to go in and reconstruct the column anteriorly by a transdiaphragmatic approach. Surgical execution is very important, otherwise you can land up in these sort of failures with implant failures, construct failures, adjacent segment kyphosis. So we need to have special attention to the other details apart from approach. Decompression remains the mainstay of neurological recovery. What I want to emphasize over here is that you need to have a good bed or so-called end plate preparation for sound grafting and reconstruction. In fusion of the spine, grafting remains the most important stage. And finally, you need to supplement the whole construct, that is decompression, grafting, with good amount of neutralizing instrumentation. So in short, we need to have a high degree of suspicion. Biopsy and drug management remain the mainstay. The indications of surgery are very specific, and special attention should be paid to the biomechanics and surgical execution. Thank you very much.